So today, this session is we're going to ask the panelists who have been working very hard, listening incredibly hard during the plenary as well as in the breakaway sessions, to reflect on the themes that have emerged and to come up with a 5 or 6 minute discussion around that. It's quite clear that in clinical research we need innovative trial design. And I think that this is a very good meeting to discuss the potential innovations. From what I've seen in the last 2 days is that the voice of the regulator, the voice of the low middle income regulator has not been heard. And I would suggest that in the next iteration of this is that we start to take these guidelines to the in-country regulators and understand the regulatory and legal framework within which to engage these innovative trial designs, as well as engaging local ethicists and coming to the ethics committees to see their take on some of the innovation. And I'm sure there'll be some innovations that are quite easy to understand, and those are the adaptive platforms that have been described. And I guess the challenge models will probably require much more engagement at a country level as we move forward, and we need to strategize how we engage the regulators and the legal framework as well as the ethics committees in the country. So I'm going to ask everyone, do you want to talk from there, or do you want to come up to the microphone? So shall we just take it from Paul onwards, or from Carla onwards? Or maybe women first, sorry, gender. I'm going to ask Carla to go first. Paul or Carla?
Can we fight now?
Fight on the table.
Right. Thanks very much, Glenda. Good afternoon, everyone. It has been a hectic 2 days, and as we have been listening to the discussions in this room and also during the group work, there are some messages that are beginning to emerge. And I think one of the very, very important messages is the need to realize that all stakeholders within the research environment need to realize that they are working towards one goal. I think for now we realize that there is the situation where the ethics committees are there in their corner and the research groups are in some corner, but we now need to realize it's time that we work together to realize that clinical trials are there so that we address the health challenges that we are facing as humankind. We've been looking at the issues around overprotection of the research participants by the research ethics committees, but it's time we realize protection is a process of negotiation. Research ethics committees are an important party in that process, realizing that the end goal is the improvement of human health. And when we look at the alternative designs, also need to realize that over the years we've been emphasizing on the randomized clinical trial as the gold standard, saying that this is what we are trying to aim at. But we then realize that research is becoming even more complex. It's not as simple as just running a randomized, double-blinded, placebo-controlled trial. Hence, finding these ways of ensuring that it's still feasible to conduct research within the shortest possible period, also using less resources. We realize that even when we look at high-income countries, resources are still limited. So it's about finding ways of ensuring that research can be conducted in the shortest possible period so that we address some health challenges. And particularly when we're looking at diseases such as Ebola, we need to realize the urgency and so the need to ensure that we minimize damage to humankind through such diseases. Hence, we're talking about these alternative designs. But mainly, when I talk from the point of view of the research ethics committees, I'm looking at the researchers who are presenting proposals to the research ethics committees describing what it is that they intend to do. And so often I see delays in processing by the research ethics committees, because there are so many questions that are being asked to the researchers. So we realize there is a long period of time during which the ethics committee is exchanging information with the researchers. But it's very, very important to emphasize that researchers need to be upfront, very clear, justify why it is that you are choosing this particular design, so that the ethics committee is not going to be making some guesses, but they make their decisions based on the justifications that would have been provided by the researchers. In looking at the various cases that we're looking at for the cluster randomized trials, there were discussions, particularly around the question, who is the research participant? And what is also beginning to emerge is the fact that we've been emphasizing so much on the research participant as this single individual, and yet we need to realize that there are some units that are participating in this research. And when we're looking at ethical review, we need to also be looking at the interests of the various units that are participating. It could be the villages, it could be the health centers, it could be the schools, and what have you. So ethical review then is supposed to look into the various measures that are going to be adopted to ensure that the interests of the various parties are going to be promoted. And when we also look at all these designs, we're also looking at the important role of community engagement, and particularly when we're looking at CHIMS, we are looking at researchers who are supposed to be playing the role of lifesavers, and yet here we are, we're looking at those researchers who are now infecting fellow human beings. So it's very, very important to engage through a process with the community of improving research literacy so that they understand clearly why it is that the researchers are proposing to conduct CHIMS with fellow human beings. That way, we also address some challenges that might arise when there are issues. Let's say, for example, one of the participants dies as a result of something else which is not in any way connected with the study. I was reminded of one particular case in Zimbabwe where we're having mass drug administration for schistosomiasis, and then there was a death involving a young girl in primary school. There was a lot of noise because people were actually saying that this girl had died because of the tablets that were being provided through the mass drug administration program in the schools. Lo and behold, when they did their investigation, they only found out that this girl, a family was staying in a squatter camp, those informal settlements. So the people, they grab electricity supplies, they do their own connections. So in so doing, this girl actually stepped over some live wires, and she was electrocuted and she died. And yet without that investigation, people were going to blame the mass drug administration program. So hence here we are looking at the important role also of pharmacovigilance in terms of how research is conducted in our various countries. When it comes to the issues around alternative trial designs, I think the important message that is also coming out clearly is that we should all be moving in the direction of embracing the alternative designs as long as they are clearly justified. So at the end of the day, what are we saying? We are saying that we all need, as various parties, to come to speed with these designs so that even as we are reviewing, and also even as we are providing oversight, and also as we are conducting the research, we are all confident in terms of the data which is going to come out. We are all quite sure about issues of safety in how the studies are being conducted.
We have a nice discussion around the importance of community engagement, public awareness, the concept that time is money, so trials should be efficient, and also opened up the discussion around the overprotection or the paternalization of ethics committees towards subjects in low and middle income country settings, and also the interplay between what is the purview of the regulators versus the purview of the ethicists versus the purview of scientific review in the country. And often there's a lot of tension between those three interfaces, particularly when you're approving an investigational drug that already has regulatory approval, how the ethics committee and scientific review happens in the context of regulatory reviews. So I'm going to ask Anand to give his view of the table, and thanks, Paul.
Thank you, Glenda. So I thought I'd done already a summary talk in the morning. But since I have to speak again and again talk about summary points, what we thought in our group, the Purple group, was that we would have a short discussion around some of the points that came up in the breakout discussion, probably share them as some of the takeaways from our perspective. So this is a collective group perspective rather than just my individual perspective. One of the areas we talked about was this whole issue around overlaps between what qualifies as research versus evaluation versus quality assurance or quality improvement, and the need for learning from systems where they have tried to approach oversight for this. And one example which was given was a Canadian system. There is an oversight system for QI studies there, which is known as the ERECI system. And if you Google that, you'll get that ARECCI, where they have tried to evolve some mechanisms of doing QI study oversight. So that might be an interesting model to look at. The other area we talked about was that there is certainly a wider need for education, which is either project-specific, if you have learnings which might be very unique to that project, but also maybe a broader education, and the need to tailor our messages and content of that education to the context. Sometimes conducting research, for example, chimp studies might be a plus, but it might also be a minus. So we need to sort of be able to know that and be able to figure out what's the right decision to be made in working with various stakeholders. The issue of capacity kept coming up, and what was reinforced in the group was that this capacity building needs to be both in high-income countries and low-income countries, low and middle-income countries, whether we're talking about researchers, whether we're talking about ethics committees. When we build training modules or assessment mechanisms, that this needs to be actually targeted across the board and not just specifically to one setting. As a part of that, safety and risk assessment mechanisms are crucial, and we need to be able to build systems which can enable that. Rather than sort of relying on one-stop ethics review as the only model, we also need to figure out various ways of building in ethical inputs which can happen on an ongoing basis, and that would be much more useful. The one area which kept getting discussed was that since CRTs are often by nature involving groups rather than individuals, would that be more amenable for community engagement in communitarian societies? So if we tend to consider that many LMICs have more communitarian rather than individual perspective, is it more amenable that studies which involve communities as groups would be more agreeable to communities rather than an individually randomized clinical trial? So that's an interesting empirical question to explore. Post-trial access, which was left as a bit of an open-ended question, we thought would be more project and intervention specific. So obligations, we tend to generalize them from our own past experiences, but this might need to be specific to the context and to the nature of the trial which we are conducting, and that I think is important as well. The other area we thought was really important was policy linkage, sort of moving from results to policy and enhancing the quality of best buy decisions, which Glenda also talked about yesterday, which policymakers need to make. So one model there is the UK MRC model, where they talk about a pathway to impact, which is essentially whenever you're planning a project or a research study, you need to build in an argument about what would be your pathway to impact if your study shows a particular result. And I think if we get our researchers to actually start thinking about that and planning for that in advance, then it might be useful, because then you're also not just looking at a research publication as your endpoint, but also beyond that, how you're try to influence policy or the next set of studies which can build on what you've learned from your own study. It's important to also work with experts in areas like cost effectiveness so that we can understand that the kind of interventions that we do, how would they play out if they were to actually be adopted by, say, a national health system, and what kind of evidence do you need for that? In the evidence hierarchy that we keep talking about, I think there was consensus within the group. We were discussing that a well-designed and conducted CRT would be as good as a conventional individually randomized RCT, but do other stakeholders also take that same view? Do they consider a well-designed CRT equivalent in terms of gold standard to an individually randomized RCT? And the answer might not yet be yes in all situations, which again goes back to the issue of doing more education in this area. The one area where there might be some issues is when you're working with health systems, and especially learning health systems, where you want to do continuously these kind of activities, you might hit a bit of a roadblock when you might have individuals who prioritize their own healthcare needs or their own decision making over what might be more amenable for a learning health system in terms of a more democratic, deliberative democracy kind of mechanism. So people would still want to be asked about decisions which might impact their health or their participation, and have as much as possible control over randomization, for example, and they would privilege individual care over even a learning health system at some point of time. So that is something you would struggle with, and I think is something for us to explore within trials. We kept talking about gatekeepers as an issue, and I was thinking, there was a conversation we were having at dinner yesterday about this confusion of gatekeepers and goalkeepers. And maybe for us, I think the target is better to think of ourselves as goalkeepers. If we're talking about pragmatic collective learning, then goalkeepers have an interesting role to play. They are part of the team, they train with the team, they have the same interest at heart which the team has. And if we as folks who work a lot on the ethics and regulatory issues consider ourselves as goalkeepers who are part of the larger team which is working towards a certain output or a certain goal as part of a larger team which wants, for example, to better health of our nations or of our citizens, then with a certain role of protection which a goalkeeper has, but yet also ensuring that we have that regular contact, that regular iterative training programs which are organized with the rest of the team, that perhaps that's an interesting model to look at. I had a sense that there was some pessimism around the situation in low and middle income countries with regards to regulations that was reflected in the morning panel in terms of the regional perspectives which were shared. But if we really explore, there is not much difference between high-income countries and low and middle-income countries, especially if you're talking about low resource settings in high-income countries. When we were revising the SIOMS guidelines, the latest version, this kept coming up, which is why we moved away from saying that the SIOMS guidelines are only for low and middle-income countries to saying they apply to any setting which might have a low resource area, because that, I think there are similar issues with inner city Baltimore. Colleagues from Hopkins will probably support that. So I think the importance of also understanding that many of these challenges apply across the board, and hence collective learning might be a better opportunity. At the same time, I think it's also an opportunity for leadership with research teams, with groups in low and middle income countries to actually do really innovative work in this area. And that might help us understand where the gaps are, where there is a need for further work. The work which was presented from Khalifi this morning is an excellent example that if you can do qualitative research, if you can do social science research, if you can do high quality CHIM studies in our settings and try to understand what the challenges are, those would be excellent learnings, not just for other low and middle income countries, but also for high income countries. Stop there.
A very nice, very rich discussion, and a kind of different theme to what Paul was saying. And it's the issue around what constitutes research and trying to bring in operational and implementation science and things like that. And also the issue of study governance, which maybe we need to articulate further, and capacity development, which is incredibly important, and the issue of reverse learning, and so that the ethics committees in the South teach the ethics committees in the North a little bit as well, and we have reverse sharing and sharing of capacity in terms of ethics committees. The community engagement has been emphasized again, and issues around post-trial access are important, and the issue of impact, policy linkage and impact is important. And I don't share the pessimism about low and middle income countries. The regulators that I've interacted with in South Africa, Malawi, Zambia, Mozambique, show the regulators show an incredible astuteness to the regulatory issues that they face, and reach out very often in the region. And maybe the ethics committees could do the same thing as the drug regulators in the country and use their neighbors to help them with the review. It might be a good way to encourage capacity development. So thanks. Mike, you next.
Yeah, thanks very much. We had a really interesting discussion yesterday and today in the yellow group just down here in the corner. I won't simply report from the group for two reasons. First of all, Joe Ali's made some really good notes, which I think everyone will get, but also many of the things are the same sort of things that Paul and Anand reported from their group. So maybe just a few thoughts to maybe that are slightly different, just to add to the discussion. One of the things I thought was really interesting, and I found it refreshing on the first day, was this emphasis. I don't know whether this was a conscious decision of the management group, but the planning group, sorry. The idea that we shouldn't focus too much on consent, and I found that really refreshing. And I think it's helpful because we have tended to place too much. We spent too much time, to be honest, thinking about consent, and consent is part of I think of it as part of an ethics ecosystem around clinical practice and research, and we need to think of it in that kind of way. I don't mean that consent isn't important, clearly it is, but sometimes it can distract our attention from other important concerns. So I often think it's a useful starting point to ask yourself something like, let's just, assuming that consent is imperfect, it's partial and so on, what protections need to be put in place? What do we need to be put in place so that people who do give consent, acknowledging that it's imperfect, that they have appropriate protection, that they're not discriminated against or unreasonably harmed as a result of their participation. And I think that's actually quite a healthy way to start thinking about these things. And actually that was manifested, I think, in much of the discussion. So there was a much more emphasis on social justice questions, equity questions, and I think that kind of discussion is needed, and not enough has been said about that. And that arose in all of the different study designs, that question about equality and justice. So I found that really, really helpful, and I think that's a good way of starting. And it was nice to come back a bit to consent today, but nice to start out with something else. So that's one thing I think that ethics has in this space not paid enough attention to justice questions, and I think that's nice. I think the other thing that ethics has tended to be bad at, perhaps not people in this room, but more broadly, I think we're not very good at coping with risk and probability in a whole range of different ways, and we're not very good at thinking about it in general, but particularly in these kind of situations where risks are going to change throughout the life of a study, and where studies become more closely integrated with clinical practice or health practice. Risks and probabilities changing over time. How does ethics deal with this? Do we need a new kind of ethics? Certainly, do we need new kinds of ethics skills to be able to engage with those and say something sensible? And I don't think we're there yet, and I think there's a lot that we can learn. And partly it comes back to this point about closer interactions between science and ethics. There's a lot that ethics can learn from those interactions as well as the other way around. A third point I thought was really nice was Joe's point on yesterday about the importance of at least sometimes not worrying too much about regulations. Does this activity sit in this box or that box? What do the rules in this particular area, region of the world say? Just say, well, let's just spend a moment thinking about it, stepping back, thinking carefully, the important place of ethical reflection. Again, that's not to say that regulation is unimportant, and it's not to say that we don't have to engage with those systems, but sometimes we jump, well, certainly in our group, and I think in much of the discussion, we jump too quickly into a kind of filing. Where does this activity, where should it be filed, and then we can talk about it. And I think that was a healthy and a helpful reminder to us that one of the reasons why our input hopefully is valuable as ethicists is that we pay attention to the importance of sustained, careful consideration of the issues. And Florencia made that point earlier too. And that comes back to a point which, I guess my fourth point, which is one I made from the floor, but I want to make it again, which I do think there's a huge amount to be learned by ethicists, but also by science, from building ethics into science, building ethics in properly as a partner from the early days of research projects. That's not as the ethics police. There's an important role for ethics police and so on, but that's not what I have in mind here. Genuine partnerships between ethicists, social scientists, and scientists of other kinds. Many of the international research collaborations that I'm involved in are collaborative in a whole range of different ways. There's multiple disciplines involved. It's very rare for any more than just a couple of the scientists involved have an in-depth knowledge of the project as a whole. That's why they collaborate with other partners, statisticians, computational biologists, and so on, because everyone has a partial knowledge which comes together to make the study successful. And my view, and I think most of the people in the room would have this view too, which is that successful science, successful and appropriate science, requires the identification of and engagement with ethical, I was tempted to say roadblocks, but ethical problems along the way, and I think that can only be done if ethics is close to science. There's a tension in ethics. Some people think, and I think this too to some degree, think it's important for ethics to be outside of independent and critical of science. The problem with that is that often the problems you're critical of and engage with are not real problems, or they're not the most important problems. There's also a space for an ethics which is close enough to science to recognize what the problems are and to engage critically with those. You give up a degree of independence, but you gain an awful lot from that. So I'd want to argue that at least some ethicists should get closer to science than they have been. And then I guess the final thing was just to come back to this point, which has been an issue over the last few days, last day or so, is this importance of rethinking the relationship between research and healthcare, or research and service provision, or quality improvement. That distinction is no longer sustainable. I think we've got to get beyond the idea that research and clinical practice are separable in practice. Many activities will be both. That doesn't mean that when we have a conversation with a participant, let's say a consent conversation, it doesn't mean we don't have to pay close attention to the different intentions and the different motivations for the piece of work that's being done. But the idea that we can put those in boxes and have different conversations in different places, I think those days are gone, or very nearly gone.
Excellent. So he brings in nice new words, the ethics ecosystem, and that's a nice term for the backwards and forwards and the evolution and the collaboration that should exist in ecosystems. So I like that term, and maybe we can develop a paper on that. What is an ethics ecosystem? He spoke a lot about justice and also the issues of risk and probability and how that evolves over change. Over time as a trial advances. And the need for ethical reflection, and he also emphasized the issue of partnerships and the interplay between independence and collaboration. And I think that means trust, is that ethics committees, ethicists, and scientists have to start to trust each other. And so it's not about independence, maybe, it's more around about that you can still maintain independence when there is a level of trust, and that maybe we should work harder at developing that collaboration and relationship between clinical trialists, trial design, and ethicists to enhance and move forward the ethics ecosystem. Thanks.
Thanks. So I'll try and report back from my group and pick up one or two of the points that haven't been already raised. I think one of the things that we kept coming back to quite often was that the ethical considerations were not really defined by the design or the study design, that actually there were quite a lot of these ethical considerations were quite common across the different study designs and were actually common to higher income and lower middle income countries, so that these weren't, although there were occasionally things that came up that might be where the ethical considerations might be different for those reasons, that largely it came down to assessing always the risk and benefit in the different contexts, and that actually it might be similar risks and benefits that were being looked at. We obviously talked first of all a bit about the when it might be appropriate to do a cluster design, and that really, again with the step wedge as well, it came down to the idea that actually the design was often about the sort of scientific need and the need to get valid results, so that it wouldn't be appropriate to obviously use a study design that wasn't going to give you the valid results. And that actually was a primary concern. And then again, it was looking then about the risk benefits and when it came down to the ethical considerations. We talked a little bit about managing consent, obviously. I mean, we felt again that a sort of a cluster design shouldn't lead to a waiver, an automatic waiver, but it may be acceptable in some situations where it's a community level intervention. So perhaps when it's for example, improving wells in villages where it would be really quite difficult to get individual consent. But we felt, and again, this is something we came back to, that weren't sort of, we could often think of a reason why we couldn't make an absolute sort of statement that this or that would be not the right approach. we talked then a bit more about the gatekeeper role, and I think that we talked very much about the gatekeeper as a sort of a positive conduit, someone who would help inform how community engagement or access to the community or acceptability of an intervention or study would actually provide that sort of information to the researcher and perhaps how the approach should be made to the community. But we also felt that the gatekeeper shouldn't consent or make a decision on behalf of the individual. There was, again, as I say, it wasn't absolute, so again, someone raised the issue about if it was a very, very low-risk intervention, perhaps, and it was community intervention, perhaps it would be appropriate in that situation. But we discussed a bit about the power dynamics and the fact that a gatekeeper might sort of either block or coerce, but also could be a facilitator, so might actually allow individuals and permit them to choose. And then there was a discussion, an example given from a study in Laos where there was multiple gatekeepers, and where you actually got the representation sort of from different parts of the community, so the youth and women as well as sort of like the other members of the community. We also talked quite a long time about the post-trial access. And this was, I think, one of the questions was whether it was ethical to start the trial, to start a trial if you knew or that there was going to inevitably be a rollout. So the policymakers had agreed that or determined that it was going to be a rollout. And we actually, one of the issues that we felt sort of came up was that, you know, sometimes it might be acceptable. I mean, we don't always know what's going to happen. So, for example, we might think at the beginning that the costs of the intervention are going to be too great, and therefore it's not, the trial isn't reasonable to do or ethical to do, but that actually if costs fall over time, perhaps the results from that trial might demonstrate the point at which something becomes cost effective. So it could still be useful to do. I mean, another situation was, I think about the responsibility to provide treatment after the trial, so the post-trial access to treatment. And there was discussions about whether that was a short-term sort of access, where it might be appropriate for the researchers or sponsors to provide a vaccine. But then we discussed the issue of something like polypill in Iran, where actually it's really unclear how long, what the duration of that might be that might be beneficial. So in fact, would it be ethical to actually continue providing that treatment? I think ultimately we came to a conclusion that actually it was really important to be explicit at the beginning. So in the trial, it was important to actually discuss these issues about post-trial access at the beginning, be explicit about them in the protocol, and actually perhaps be explicit that the commitment wouldn't always be to guarantee that something would continue afterwards. The issue about rolling something out really became an issue about would the research actually influence the rollout. So might it actually lead to a situation where you might stop the rollout, or you might not start it elsewhere? So so really it wasn't so much, again, a lot of the questions we sort of altered and adapted and questioned the questions. So that question about would we do it if we knew there was going to be a rollout, we were actually talking about, well, maybe you would get benefit because actually you would not roll it out elsewhere because you would understand more about it, even if you had already committed to rolling it out in one place. Or you might actually change the intervention as you roll it out, perhaps, or amend it. We did get a lot of discussion. Came into a lot of discussion about equipoise, and there was certainly a point made about that not being a great term, that it was sort of too much sort of assumed there was a single point, and that really a lot of what research should address is actually the remaining uncertainty. And that might be the uncertainty of moving something that's understood to be effective in a controlled situation into a real world, or something that's perhaps been shown to be effective in a higher income country into a lower middle income country. We talked a bit about standard of care. I mean, I think the main thing that came out of that was the importance of sustainability, so that the biggest concern was where you perhaps started a care and then stopped it, and that perhaps there were two examples given. One was where sort of a vaccine was given, so the usual standard care was enhanced by giving a vaccine, but that was something that could then be given to the population as a one-off. But then if it was something like a nutritional supplement that was used to augment standard care, because that improved the assessment of whatever intervention, and that was stopped afterwards, whether that was appropriate because it was something you couldn't sustain. I think sort of finally, I think just talking about the CHIMs, we felt again that there wasn't a sort of an absolute issue about the upper limit of risk, and that it was actually, perhaps there would be situations where there'd be lower tolerance of risk if the benefit was indirect to the individual. But also we noted that perceptions of risk will differ, and that actually these may be based on, well, these may differ because living in an endemic area, the perception of disease is different, or it may be that there's cultural considerations in particular areas which alter the perception of risk. I think finally, the last issue that we discussed in some detail was the bystander risk, and the difference between something that was perhaps identifiable bystander risk, and whether that meant that really you should be consenting the bystanders, because actually they should almost become participants, because to understand whether the risk is acceptable and they're happy to be involved in the trial because they are actually affected by the intervention. But where it was an unidentifiable bystander, for example, it may be more difficult, obviously, to do that. And we did then discuss whether in an endemic area, actually the bystanders, although you couldn't identify them, might actually benefit because of the outcomes of the trial, might actually lower the risk in the area eventually. So there was a potential that there was actually benefits to those. So again, I think a lot of our discussions came down to thinking about the risks and benefits in different situations, and really that was where we ended up not being able to come to absolute conclusions.
Thanks, Rachel. So Rachel brings in the detachment of the ethical consideration in the clinical trial design. And it sometimes appears that the scientific need is proposed first, and then afterwards the risk-benefit may occur. The gatekeeper issue around who makes the decision, and the issues around ethics and consent and power dynamics within gatekeepers are an important thing to talk about. The post-trial access issues, I think, was incredibly interesting, and maybe we need a further debate on that, because often the interventions we do may not have, may not be licensed in country, and the product development process may take a while to get licensed in the country. And so there needs to be access committees that allow the off-label use of interventions that are not yet regulated or proposed by the in-country government. So I think that's quite a complex thing, how you balance post-trial access to a drug that may not be licensed in the country, and how we work with the access committee to allow for a 3B or phase 4 before licensure occurs. So I think the issue of post-trial access for investigational drugs that are not available is a complex thing, and I would think it also goes under the scientific governance that was spoken about earlier, that scientific governance is also about access, global access and local access, and how we roll out interventions while we're waiting for the market strategy or the target product profile or the clinical development pathway. And that's an important relationship that we need to engage with the people that are the drug discoverers. Often people who are non-pharma related clinical trials may not have a market strategy or may not have licensure in line, and suddenly when your vaccine works, you're suddenly trying to find a pharma partner to take it to scale. And maybe scientific governance needs to take into account that when you lack a pharma partner, what do you do if your product is successful? So I think that's an important thing, how we use off-label use of drugs. I like the idea of bystander risk and bystander benefit, and sure, you can definitely in vaccine trials see that there may be bystander benefit, but what about bystander risk, and how do we, in terms of scientific governance, do we address that? And again, the moving target of equipoise, and that it changes over time, and we need to address that. You spoke about the standard of care and the issues around sustainability, which is quite similar to the kind of challenges that you have with post-trial access. When I first heard chimps, I thought it was chimps, and it was like non-human primate challenge models. And so maybe we should change the name from chimps, because it kind of implies animal challenge, the chimp study or the chimp study. Maybe there's a nicer way to call human challenge studies, so that it doesn't sound like animal experimentation. So just a comment that maybe we need a different name for chimps, for those people who don't know what chimps are. And the challenges that we have with the chimps study and the interplay between chimps being a transactional relationship and a protection relationship, and how we interface a transaction versus a protection relationship in a chimp study. I'm going to ask Carla to finish, and then we'll open it up for discussion after Carla's had her input.
Okay, so I think the Blue Group did a very, very good job avoiding the discussion about consent, because I was looking at my notes and we really said very little about that. We spent a lot of time discussing the justification for using these novel designs and the need to start with the best trial design, the best methodology from a scientific perspective. And in the cases that we discussed, we agreed that the designs that were proposed were pertinent, but we're also discussing to what extent they were the best designs, and whether should we use this in all cases. And so we felt a little bit in need of more information. We felt a bit uncomfortable because it seemed that we could kind of like pick and choose from a Bayesian statistic framework and then a probabilistic statistic framework. And I think that our need to have more clarity about when to opt for one framework versus the other, or to have a better comparison of what each type of design brings, I think to some extent was well addressed in the last talk. We had a number of questions about this, and I think we scared the statistician out of the group because of that. And one issue that we came coming to again and again was the need to build local capacity to analyze, produce, and also accept these novel designs. And the point was strongly made by the group that LMICs must be proactive and take ownership and assume responsibility in this need to build capacity, as opposed to passively wait for that to be the capacity to be passed to them. And we discussed a number of possible challenges when, in the context of we were thinking, well, should we expand? Should we use these great designs in all cases? So we discussed, for example, challenges that they might imply regarding, for example, keeping fidelity among clusters, which is specifically a problem with behavioral interventions. In the context of the discussion about the appropriateness of using these novel designs, we kept referring to, as it were, like the continuum of evidence, the fact that that we start with no evidence and you progressively develop it, and which is also true in other. It's not only true in the case of the novel designs. That's how research progresses. You don't start with like 0 and then suddenly there's a big block, and so we were trying to see what is it that we already know about this continuous production of evidence that can illuminate the discussion about the novel designs. And we found it challenging to identify, as it were, to carve the space in this continuum where, for example, stepwatch trials should be reasonably conducted. So that led us to the discussion about, at some point in this continuum of producing evidence, you go from answering a research question to rolling out an intervention. And so we did spend some time, and that's the research versus non-research discussion, and what would generalizability mean. And so specifically with the research versus non-research discussion, and I think that's something that hasn't been pointed out before, we highlighted that a specific reason to something that happens to make this confusion even, to increase this confusion, is that especially in LMICs, we have pragmatic reasons to cast something as research while we all know it's not, and it's just because that's where the funding is. And so that was a further layer of difficulty to the discussion that we had. And we noticed that some of the designs that we're discussing could be well used, like stepwatch could be used for research and non-research purpose. And we concur with a theme that was also brought up in the plenary, that there's some need for ethics oversight, even if something is not research, For example, if it's strictly program evaluation of something that has been already proven effective, but that doesn't, a need for ethical oversight for not research doesn't mean that we are considering reproducing the ethics review committee model. With regards to post-trial access, we raised the worry that we were treating differently the provision of drugs after a study has been continued and the drugs have been proving beneficial for the population versus giving the $10 incentive. So we worried that we were having different standards depending on the type of intervention that were at stake, and we found that problematic. Our discussion of chimps was a little bit different, not only because it was shorter, but because we considered it be some sort of like different animal, no pun intended with your comment about chimps. We felt that this, well, it's definitely not a novel trial design. We saw it had been done for a long time, and we felt like we were more familiar and felt more, in general, feel like capable to do an ethics evaluation of these designs using the available guidance. We discussed the scientific and ethical reasons to conduct chimps in LMICs, and we're trying to identify what are specific challenges and identify that those were challenges posed by poor infrastructure, for example, because of overwhelmed health systems and unmet needs of populations. But yeah, I think that was pretty much a summary of our discussion.
I was in a group, and so I can attest that her report is very valid and great. We were talking last night, and I won't say with who, about the value of being the minute taker in a meeting, because you can always mold the minutes to the way you want it. But we didn't talk about the power of being the chair of the meeting, because you can always mold your session to the way you want it and pick up the stuff that you think is important. But what I like about what Carla said is the issue around the novel design and looking at the best methodology and the best designs. And because we didn't have a statistician, really, we needed some more information about the robustness of some of the clinical trial designs. We spoke about the need to build local capacity to interrogate the novel designs in a way that we probably can't at the moment, given our statistical capabilities. And that I also agree that the low and middle income countries need to be a lot more proactive in their engagement with the novel designs. I like your term continuum of evidence, because that's exactly what we do in clinical research, and that even programs that are in practice should be continued to be evaluated. And it reminds me of we used to dish out steroids for preterm delivery, and that was standard of care. And then there was a study that was done that demonstrated that in low middle income countries, in fact, there was no benefit. So the importance of continuing evaluating your intervention, because what may apply in the first world may not be what's in the low middle income countries, and what we think brings care and health needs to continue to be reevaluated to make sure that we get it right. So I like the idea of the continuum of evidence and the continuum of evaluation beyond the clinical trial. The issue of ethical oversight, so this is what I would call scientific governance, which would include the ethical oversight. And then again, the challenge of CHIMS in low resource settings and the balance between burden of disease and how we execute CHIMS in situations where the resources may be limited. And so I think what we have heard from everybody don't go away, because they're going to ask you some questions now, is we've heard how rich the discussion was and how each table picked up different themes, and there's some wonderful concepts that have come out from this. Maybe because I'm not an ethicist or a statistician, the language that has come out here has been incredibly enriching for a clinical trialist. And I hope that we can take some of these concepts into clinical trials and start thinking about how we improve scientific governance, how we address access, post-trial access to the intervention, in the face of lack of licensure and it being available in the country? What do we do in those situations? How do we design phase 3B and 4 studies to ensure that we address the post-trial benefit issues? And maybe what we haven't discussed here is the interplay between investigator-driven clinical trials and clinical trials that are funded by pharmaceutical companies, which ironically may have better chance of being licensed and rolled out than the kind of trials that some of the investigators are involved in who don't have pharma partners. And maybe that's a different conversation that one can have around post-trial access. So post-trial access is complex and nuanced, and maybe we need to have a whole meeting on what it means to have post-trial access. So I'm going to open up the discussion to the audience, and it's your chance to mold the minutes or the session to the way you want it to go. And so we do have some minutes. Where's Adrian? How many minutes do we have? Where are you, Adrian? She's gone.
She's at the back. 15.
15. So we're ready to start the discussion of the session and the interrogation of my prerogative as chair to make some bold statements. Peter.
Thank you. Just a couple reactions and observations to share. Just thinking about the discussion about having some ethical, I guess not oversight, but input into some public health decision-making or program implementation. It isn't research or isn't clinical trials. And just thinking about some things we did with PEPFAR in Southern Africa and implementing novel reimbursement schemes for voluntary medical male circumcision, or the decision about whether to go to a single tablet regimen for treatment that was going to cost, still very inexpensive, but it was the difference of hundreds of thousands of people treatment years with these decisions. And I think we made good decisions, but we certainly didn't have our resident ethicist at the table with us and helping to articulate what some of the trade-offs that we were making. So I think that's a great idea and something to pursue beyond, somehow to have that input beyond the research world. Some of the discussions about guidelines or the need for new guidelines have been about whether there needs to be new guidance or additional guidance in moving from high-income countries to lower-income countries, or about some of these so-called novel trial designs. Even community randomized trials have been around for decades, so some of them aren't quite so novel and maybe just being a parsimonious Yankee. It seems like there's good guidelines, and much of what's needed is more training materials, case studies, and whatever new guidance is developed to really have a very robust implementation, dissemination plan as part of that. I think will go a long way in addition to whatever new guidance is made. Lastly, I just wanted to say this is my second such meeting. I was in ANSI 2 years ago, and just how much I appreciate the diversity, the geographic diversity, the discipline diversity as part of this. And so from the Fogarty International Center, really pleased to see this work going on, and with Barbara and Joe as part of this. Just really appreciate the richness of this and the importance of this, and to see it continue. Thank you.
I agree. I've had the most fabulous 2 days for a long time just listening to the discussion. So I agree with the richness of the discussion. And thank you for funding, and please continue to fund this session, this meeting. And the MRC has agreed to co-fund the next one when it's in Cape Town.
My first meeting, so I'm thankful to be invited. I've also been really impressed with the diversity in terms of field of expertise as well as the geographic diversity. So the one point I wanted to make was this thing that's come up a number of times, which is this idea of trying to integrate more the researchers and the ethicists when looking at study designs and rolling out the studies. So I wonder if one way to try and make that happen is looking at the funders in the room. If we shouldn't look at almost including ethicists on our research panels, our research study groupings, the same way that we do with our biostatisticians. So when we write up our study designs, we have the biostats person and we've got the ethicist. They're listed as part of our research team. And if the funding agencies were to start saying, hey, where's your ethicist on your research team, maybe then we would start to pay more attention to that. And hopefully we would have, initially we might have to have that, those ethicists from developed countries, but then hopefully we would get to the point where those ethicists are part of our research teams from within the low middle income countries. And so maybe that's one way to try and move that process along.
Yeah, I think it's an important idea. So currently, most of us have community advisory boards and community representation on our studies. But I think having an ethics representation is a nice idea. Mike?
I'm going to now get Russell recognize this. I'm going to now do a very classic kind of pragmatic ethicist backpedaling. Because I was speaking primarily to ethicists, I think, in my comments and saying, that I think it's good for us to be closer to science. And I also do think it's a good idea for ethicists to be involved in science from the science point of view. I'm not sure I want to argue that every study has to have an ethicist involved, but I do think what I would hope would be that the funder would. And there are two reasons to that, actually. One is, so just to finish, so one is I think the funder should look at a study, and perhaps having a funder on an ethicist on the funding committee is a good idea, and say, is this the kind of study that needs ethics input? I think that would be a reasonable question to ask. I really personally wouldn't want to go down the road saying, you have to get a token ethicist on the application, otherwise you don't get the grant. I think that's a mistake.
Can't have ethics capture. So in South Africa we have state capture, so we can't get ethics capture.
Yeah, it has to be real work. There has to be real work to be done, and where there is, I think it's a really important role. But there's another reason to it, and I think my experience of working close to science, Raina Rapp published a book a long time ago in a completely different area of medical ethics to do with reproductive medicine. And she referred to the first women in the US who went through amniocentesis as moral pioneers. So the idea that people, encountering a new technology for the first time had a kind of moral pioneer status. And I think that many of the scientists that I've worked with have something about them. And I've found in many cases, very sophisticated and thoughtful ethical reflection on behalf of scientists. So I wouldn't want to say there's necessarily a role, there needs to be an ethicist involved in every case, but I think there is merit in that sometimes.
Maybe you may not be aware, but funders do get ethical opinions on studies. And certainly when the MRC decided to co-fund the ECHO study, we did engage with ethical review. And when we initiated the VRC01 AMP study, which was conducted in both men and women, and in the North America MSM, we had more access to PrEP than in the sub-Saharan African, we did get an ethical review on that. In fact, from the NIH, Christine Grady led that ethical review. So I think the funders are, and I don't want to speak on behalf of the Gates Foundation or the NIH, but I have seen a number of ethical reviews by some of the big projects that that have happened. I'm not too sure about Wellcome, but certainly I've seen Gates ethical review and NIH, and my own, as a funder, we've done that as well. We have the gentleman in the blue, the gentleman in the blue, the lady in the blue, and the lady in...
So Jeremy Sugarman, just a couple of quick comments. There are several different models for intercalating ethics expertise into clinical trials that have been employed. In the HIV prevention trials network, for instance, we place an ethics representative on every protocol as it's being developed to address the ethical issues in real time with the team. And in accord with that, we also have the ethics working group that looks at more at an arm's distance. Through the NIH Research Collaboratory, which is a series of pragmatic clinical trials, many of which involve cluster randomization, we have an ethics core that reviews things not embedded in the team, picking up on Mike's point that a different kind of ethics input is what's needed. And through the Resuscitation's Outcome Consortium, which is a completely different one of research in the emergency setting, we had a formalized ethics review in place. So there are multiple models. One size doesn't fit all, but there are ways to do that that can help facilitate the research being done and those problems addressed in real time. I'd be happy to talk more about it if there weren't so many blue and white people getting ready to talk.
We have, in the front here, we have do you still have a question?
This is just a comment. I think I don't like the idea of alternative designs. I don't know why. It's about the phrase itself. I think every study design it's useful, but some study designs are more useful than others depending on the research question. So I think the message that we need to kind of like communicate is what is the appropriate study design to address a particular research question. At the moment, what we are seeing is a lot of people that are coming to us as statisticians saying, actually, I've got this research question, but I want to use an adaptive design, which is kind of like the wrong way of thinking, because you ask them to say, what exactly are you trying to achieve and address? Then they realize actually they need a different study design for that particular question. So that's my comment.
The hypothesis should come first, and then the methods, how to achieve your hypothesis, should be secondary. We have a question at the back.
Yeah, thank you. I've now got two questions. But I think following on from the discussion of involving ethics in the process of designing studies of various sorts, might we be able to say anything concrete about how the role of ethics committees might change as a direct result of that? For example, I mean, most ethics committees are asked to comment given a particular design. They rarely have the option of suggesting an alternative design from the one that's being proposed. And sometimes then they're not, encouraged to comment on the science at all, as we've already been hearing. So given that we've got some ethics, upstream, might they be, feeling more confident about being able to, to voice their opinions on the science?
Does anyone want to respond to that? I think that's an important question. So by the time it gets to the ethics committee, the protocol has been designed. And is there a way of interacting with the ethics committee before you finalize your protocol to engage with the design?
Yeah. Okay, let me try and address that particular point by also saying that, quoting from the African situation, right now we are at this point where we are developing some leadership in the area of research ethics. You might be aware that through the FOGAT-funded programs now we've got doctoral programs, but we also have postdocs. So the idea is to develop people with advanced knowledge who can assist in the resolution of all these issues. But right now we're also at that point where we are having the professionalization of the area or the positions of bioethicists in institutions. So we are getting to that point where we have people with expertise who can also assist even in the institutions in resolving these issues. Now, going to the issues around the ethics committees commenting on the science aspects. First and foremost, we are also witnessing a change with regards to the role of research ethics committees with lots of the researchers and also even networks actually coming up front to the ethics committees and requesting for advice even before they present the finalized protocol. So I think that's a positive move. But also, in my experience working with the research ethics committees, I've seen protocols, some of them are designed by professors, some of them are for PhDs, with so many flaws in terms of the science. And so as ethics committees, we are then making some suggestions to say there are some weaknesses here that need to be attended to. There are issues in terms of how you put across those the comments to the researchers. So it's not about instructing, but it's about showing someone that there are some weaknesses here that might actually lead to weaknesses in terms of the data that you are going to harvest through this particular study. And I'm glad to say, as we pass our comments to the investigators, we receive very, very positive feedback. Some proposals would have passed through the higher degrees committees, only to realize that there were major flaws. In one particular case, we had the supervisor of a PhD student coming back to the ethics committee and saying, could you please let me know who reviewed this particular study, because the comments were just so useful. The student was going to conduct a study using some archaic techniques, and a member of the ethics committee actually assisted in ensuring that the PhD study would actually be improved. So there are some people who think that ethics committees should not be commenting on the science, but the ethics committee cannot leave a flawed study to proceed just because we are saying our role is to comment on the ethics. You cannot separate the ethics and the science.
A good scientific design is a good ethical design. That is, we have just two last comments. So I'm going to allow you to have your second question, and then we're going to give you the mic unless Adrian gives us more time.
Yes, very quickly. The second comment was picking up your thought that everything starts with a scientific question, and the design must be scientifically appropriate to answer the question. But there could well be a role for ethics in helping frame the right questions to ask in the relevant context. I mean, we could talk at length about that, but I know that we're pushed for time, so it's just a quick comment.
And this is just a comment on the marketing of chimps. I completely agree, it sounds way too much like chimp. So I was thinking controlled human infection challenge, but you have to pronounce it the French way, like chic.
Chic.
Otherwise, it's like chick, and then you're back to square one. So.
I like it. So can we move? Is there a resolution that we change it to chic? I like that. Adrian, are we finished? Are we finished for time? So I think this is a great session, and I want to thank thank you all because of you we had this wonderful, rich dialogue, and so it's quite clear that the participants did their job over the last 2 days. So thank you very much.